Hi, everybody. My name is Amber Rose. I'm a licensed clinical social worker, and this is our presentation on harm reduction strategies for self-harm. Some goals for today. So first goal is understand the limitations of harm reduction strategies, and how to assess if the strategies are going to be appropriate for clients. Understand harm reduction, harm minimization techniques for people struggling with self-harm. Be able to educate caregivers and support people on the strategies, and increasing buy-in for those caregivers and support people. And then educating clients and support people on means restriction and when to contact a professional at crisis center, and then when to call for emergency services. Um, so a couple quick things as far as introduction, some vocab things. So harm reduction or minimization. I'm going to use these pretty interchangeably throughout the presentation today. What that means is exactly what it sounds like. It means ways to reduce harm outside of like an abstinence only model. So everything that we're talking about today is recognizing that models or techniques that are just saying like, don't self-harm can put us in a pretty tough spot. So talking about ways to reduce harm while working towards an eventual goal of reducing self-harming behaviors, and then eventually, hopefully, eliminating self-harming behaviors completely. Means restriction, we have a full slide on this later, but just pretty quickly, it is restricting access to lethal or highly dangerous means of self-harm. You'll also hear that term used a lot when we're talking about suicidal ideation or suicidal behavior. We're going to use it a little bit differently for harm reduction. Crisis is a word that I'm going to use when I am talking about somebody who is no longer safe to be outpatient. So if I'm talking about somebody in crisis, they are either really, really close to that line of not being able to continue outpatient treatment and needing a higher level of care, or they are there, they need to seek emergency care. And then this acronym NSSI is non-suicidal self-injury. So that is any kind of self-injury or self-harm that is not with the intent of ending one's life. Some ground rules here. I'm going to say things plainly. I'm going to say things as directly as possible. And if you want to reach out to me just to ask any questions, I would encourage you to do the same. We've got to use direct language when we're talking about hard things so that we make sure we're all on the same page. And then my other ground rule, just for those of you watching this presentation, is please take a break if needed, especially because this is a recorded CEU. If you need to pause, if you need to come back to it later, if you decide that this is not something that you can complete, that is okay. Take your time, step away, take a break, get you some water, stretch, whatever you need to do, take care of yourself while you're watching this. There will be no images of any sharps or any wounds during this presentation, but I will talk about both sharps and wounds and specific types of self-injury. And implements as well. So keep that in mind as we're kind of jumping into the presentation. The slide that I go more in detail with some of those things, it says on the slide, like, this is the slide that we talked about at the beginning. So you'll know it when you see it. And if you need to skip over that part, that's totally okay. So some quick limitations of what we're going to talk about. There are obviously some big pros to talking about harm reduction for self-harm, and that's why I'm doing it. And those are, one, it's evidence-based. There's a ton of evidence for self-harm for a lot of different things, not just for self-injury, but we hear about I think I said that weird. There's a ton of evidence for harm reduction strategies for self-harm, but also for other things. So you'll hear about harm reduction strategies a lot when it comes to substance use and abuse, when it comes to like other things besides this. So the evidence is there, it's effective, and this is also something that is used throughout like the KC metro area. There's a lot of different agencies that talk about harm reduction strategies, that talk about means restriction, that use the same language. And I think that just kind of knowing where we're at geographically and knowing what the people around us in the community are also talking to clients, talking to support people about, it gives us a little bit more of that like buy-in when all of the experts in the room, or many of the experts in the room, are using a lot of the same language and a lot of the same techniques. So biggest con, both that you'll see in the literature and that I always run into with my own clients, is that caregiver buy-in. When we are talking to caregivers and support people about harm reduction strategies, we are saying, I'm not expecting your kid to stop self-injury right now, today, and never do it again. And caregivers don't always love that. So there is a lot of work that can go into that buy-in, and we'll talk about that in a later slide. Contraindications. So if we have a client coming in with high risk suicidal behavior, lots of SI, lots of just risk, impulse control, there are times that this is not appropriate. And usually that is when we are kind of approaching that crisis state of this person is not going to be safe to remain outpatient. And that is something that you should be assessing at every interaction with your clients, of course, but especially when you're talking about harm reduction, there's going to be a point where we're going to say, okay, these are our goal strategies and this is where we want to be, but right now we can't be there. And so let's, kind of take this other step, and we're not talking about harm reduction anymore, but we're talking about really like crisis prevention, and how to get away from that place where you're not safe to have access to any means. So some quick statistics on self-injury, and we're going just kind of through some different age ranges here. Adults, aside from very young children, are the least likely group of people to report follow through with self-injury. So follow through means actually acting on the urge or the impulse. Only about 5% of adults from the survey reported having self-injured in their lifetime, which we'll come back to that here in a second. Teens, as expected, highest rate of reported self-injurious behaviors, with about 17% of teens disclosing self-injury at least once. College students, about 15%, so that number goes down a little bit from teens. And then the gender gap here, and this is not gone into much in the study about where they categorize people here. Women more likely to self-harm, men about 35% of the total reported cases of self-injury. So some kind of things about these statistics. These statistics that are referenced here at the end are the ones that I found referenced the most. It seemed like a really well-rounded study. However, nothing is perfect. Obviously, the stats between adults and teens don't add up. The verbiage here is 5% of adults report having self-injured in their lifetime, and 17% of teens say that they have engaged in self-injurious behavior. We got a 12% gap, something's going on there. It's probably because of guilt and shame associated with self-injury. And then we know that the stats are higher in the LGBTQ community. Obviously, my gender gap here says men and women. We know that the highest rate in the LGBTQ community is among bisexual females, bisexual women. They have the most significant stats there. So let's talk about the types of self-harm. So when we say self-harm versus self-injury, it's important that we're sometimes needing to separate those two things. Often when we're saying self-harm, we're meaning self-injury, and that's the thing that we're talking about the most frequently in this presentation specifically, and also in a lot of the statistics. But self-harm is a broader umbrella term that means more than just self-injury. So 5 categories here. With non-suicidal self-injury being the first, and the one that we're talking about the most today. Disordered eating is categorized in the self-harm umbrella. It's another form of self-harm sometimes. Again, that disordered eating in and of itself is an umbrella term, and so disordered eating is not always done with the intention of self-harm or happening with the intention of self-harm, but it's falling here under that umbrella. High risk sexual behavior. So when we have a person who is engaging in sexual behavior that they themselves believe to be morally wrong as a form of self-punishment, or engaging in physically risky behavior, that is a form of self-harm. Substance use, again, we've got a lot of gray area here of this can be self-harm. It is not always self-harm, but substance use is another thing that we look at under the self-harm umbrella. And then the peak, the high point of our gray area here is body modification. So your tattoos, your piercings, other forms of body modification that can be painful, can be self-harm. This is something that the literature debates, that professionals debate, that I have debated with my friends and colleagues as I present to you as a fairly tattooed person. What you need to assess here when you're working with a person that you are trying to figure out, like, is this a self-harm behavior? Are you self-harming with your body modification, with the things that you're doing? Is what's the motivation? What's your experience? What is your like general level of impulse control and how you're able to think through your decisions? And that's going to help you, as the clinician, as the person assessing what's happening, better understand what's going on with that particular client. Very, very, very individualized there as you're assessing that. Another note here, the co-occurrence between self-injurious behavior and eating disorders is super, super high, 55%, and especially seen with adolescents. So if you have a person that you are working with that is experiencing or that has disclosed either disordered eating behaviors or self-injurious behavior, you need to be assessing for the other. You need to be talking about, obviously motivations there, but also making sure that you're not dealing with both of those things at the same time. This is one of the quotes that I pulled just because I feel like it is so nuanced, and that there's a lot that we can unpack here. So about a third of students reporting non-suicidal self-injury in the studies conducted said that they had hurt themselves so badly that they should have been seen by a medical professional, but only 5% sought treatment. And this, I think, really struck me, and has influenced a lot the way that I go about this conversation with caregivers and support people, and obviously with clients directly, because this is huge. When we have somebody who is engaging in self-injurious behaviors and doesn't know next steps, doesn't know what to do if they've become severely hurt, doesn't know when it's appropriate to call a medical professional, or has not talked about a plan for how to do that, there's a lot of risk there in not getting treated quickly, not getting treated appropriately, not reaching out to a parent, a loved one, a support person to get support moving towards being seen by a medical professional when they need to. This is the slide. This is the slide that I want you to be taking breaks if you need to. I want you to be thinking about yourself and feeling what's happening with you while I'm talking about these things, because we're going to talk about intense stuff. So as I go through this slide, top to bottom, left to right, like reading a book, this is kind of your levels of intensity. I want you to think of this slide as like a scale of kind of what you're doing with your client and increasing in intensity over time. So very first thing that you're doing with your client before you're talking about harm reduction strategies, before you're talking about much of anything, is safety planning. Is you're identifying what your coping skills are right now before we do anything else, before we add anything. Like, what is our ground zero? Where are we starting? And that's your safety planning. So safety planning is going to and should look different for every single client, because it should be particular to them. It should be created collaboratively with them. And if you can get releases to do so, if your client is consenting to do so, it should also involve some support people. So in safety planning, we're talking about coping skills first. We're talking about distraction techniques. We're talking about your grounding, and then your outside support. So who are the people that you can reach out to? How do you reach out to those people? So if you're in a moment where you're needing to use this safety plan and you're putting this person on this safety plan, do they know that you're putting them here? Have they consented to being a part of your safety plan? And what do you do if you are feeling shame about contacting this person, if you're feeling guilt about needing to contact this person, or if this person does not answer? Because people sometimes don't answer, and that cannot be the last line of defense if this is just a person in your life. And then from there, what are the steps beyond those support people in your life into, your hotline numbers, your local emergency department, and when to seek out that higher level of care. So first step is safety planning. From there, we're going to talk about delay and urge monitoring. This isn't something that I think a lot of people kind of put in the bucket of harm reduction. But statistically, we know that this is a harm reduction strategy because the longer you delay or sit with or move through the urge for self-harm, one, the less likely you are to actually complete the self-injurious behavior. But two, there is also evidence that as you move through the urge, the injury that you complete at the time that you do move forward with self-injury, if that's what's happening, tends to be less severe. This is not all the time, but there is evidence that's saying that the further you get through that urge, the closer you are to the end of that wave that you move through with a self-harm urge or self-injurious urge, the less likely you are to complete the urge and the less likely it is to be a severe injury. So talking to clients about how to do urge monitoring, and like I'm making notes about what my triggers are. I'm making notes about how long my impulse or urge to self-harm is lasting, about what types of things are helping me distract from that. And that's evidence that you guys are then able to use the next time you meet during future sessions to really like put some great like tools and coping skills into, okay, now we know how long it lasts and we know what it feels like and we know what some triggers are, and now we're going to work collaboratively to manage those triggers, build some resilience to some of those things. There are also some apps that we can talk about here. So there is an app called Calm Harm that is really great for like getting you through that initial urge. It kind of uses like even the wave visual of like surfing the wave of that urge. The Finch app is another really good one that has a lot of like grounding tools built in. So if you have a client that when you're doing safety planning is like brand new to therapy, brand new to even like disclosing or talking to somebody about this, does not have a lot of like skills or tools that they've already developed, as you move into, okay, we've got a safety plan for like right now today, and now let's start to flesh out some of these coping skills and some of these strategies, then adding in like an app to use, something to go to as they like practice and learn those skills can be really helpful. There's other ones as well, of course. There's the Headspace app, the Calm app. There's tons of things out there. Some of them are paid, and know as you're suggesting this to your clients, know your population. Know if you have somebody that's going to be able to pay for an app, or if this is somebody that you need to make sure that the things that you're suggesting for apps or tools are free. The next part into like really stepping into harm minimization is going to be some anatomy education. And this is where I want to circle back to our contraindicated population. When you have a client who has lots of suicidal ideation or is at high risk of suicidal behavior, you're not doing this part. This does not happen with a highly suicidal client because it's not safe. This is the part of the strategy that is best for clients that engage in self-injurious behaviors but are not doing or not having a lot of SI. If they have any SI, it's very passive. There hasn't been a plan. There's not a historical attempt. And if there is a historical attempt, it was a long time ago. And they have very, very low ideation, if any ideation right now. Because what we're doing here is we're teaching a client as is appropriate with our profession and the boundaries of your individual ethics with your group, if you're a social worker, if you're another group, what's appropriate for you to teach the client. But basic anatomy education can be really, really helpful here, especially because with teens and adolescents, a lot of the self-injury that we see is on the inside of the forearm. And that's a place where if somebody has a really intense urge and is not meaning to do significant damage to themselves, they can do a lot of damage. So with my teens specifically, as I'm talking about that safety planning, those coping skills, I am putting some information away in the back of my brain that's going to help me with this anatomy point. So if I have a teen who is mostly self-harming right here on this part of their body, and I also know that they're a band kid, we're talking about, hey, there's like a lot going on in this part of your body. Like wiggle your fingers like you would when you're playing your instrument. See how you can see the tendons moving in your arm as you do that. You need those tendons. Those are important. One of your biggest coping skills is to be able to play your instrument. And you're sharing with me that a lot of your self-injury is happening on that part of your body. Our goal is to stop the self-injury, but between now and reaching that goal, can we find parts of your body that are going to be more resistant to harm? So this is parts of your body that are a little bit more fleshy, a little bit more muscle versus, surface tendon or surface vein, because there's also a lot of, there's blood that goes through there. And also for people that are engaging a lot of self-injury on their legs, there's a big difference between engaging in injurious behavior on the inner thigh versus using like the tops or the outside of your leg, because again, if you are accidentally harming yourself more deeply than you intended because of the intensity of an urge, you can hurt yourself a lot more on those inner thigh areas than you could on the upper or the outer thigh, or on the inner forearm than even like the outer upper forearm, or using the upper arm. This is a conversation that I do have directly with my client if it is a client who it's appropriate to have it with. But this is also a conversation that I will have with caregivers and saying like, hey, we're going to talk about some really tough, uncomfortable body stuff right now, but like these are things that you, caregiver, need to be thinking about. Because sometimes the reason that, especially adolescents, but also adults as well, choose the areas of their body that they choose is because they're not going to be seen. So somebody who is doing a lot of self-harm on the inner thigh is because it's not an area a lot of people are looking at, whereas the upper or the outer thigh is an area that people see. So those are things to also be teaching caregivers about as we're talking about how to keep people safe through their journey with therapy and through their recovery. Restricting lethal means has its own slide, so I'm not going to spend a bunch of time on that right now, but like put a pin in that. That's going to come here in a second. Access to clean and appropriate implements. Again, this is a conversation that I have both with the client and then with support people that I have the client's consent to talk to, because it is one of those things that I see parents do the fastest. I'm going to take every sharp in the world and anything that could be even a little bit potentially dangerous away from the client. And that can lead to some desperation, and to a person using things that would not be as clean as they should be using in their self-injurious behaviors. But there is also kind of this line that we have to find here in I'm about to talk specifically about sharps and also a little bit about wounds. Know that as I continue talking, because this is a tough part of this presentation. So a person that is going to self-injure, we are accepting with harm reduction that it's going to happen. Sometimes they're not going to make it through every urge without self-injury. So when I say clean and appropriate implements, this means that I'm talking to the kid about what a clean implement means. You're not using your dirty craft scissors, and also what an appropriate implement means. So appropriate means sharp enough, but not too sharp. And the reason that I say it that way is that if they are going to self-injure, it needs to be sharp enough that it's not tearing. Somebody that has no access to sharp implements and is choosing to self-injure often is resorting to implements, a lot of force, which can do a really significant amount of damage. It can cause a lot of scarring, some longer term side effects there that we don't want our clients to be experiencing. But there's also too sharp. So there might be implements that are so sharp that a person who typically engages in a superficial injury is cutting deeper than they're intending to, because their implement is really sharp, because they're not experiencing a lot of pain, because the implement is very sharp. And sometimes pain is one of the perceived benefits of self-injury. So we need to find that fine line between being sharp enough and being too sharp. Typically, I do have a specific conversation with my client about what they are using, so that I'm able to guide that without giving ideas. I'm not throwing out, scissors versus X-Acto versus whatever. I'm not going to sit here and give you things to think about, which sometimes parents do when they take away sharps. They'll take away things that the kid hadn't considered yet. Now, oh, I could do that in the future. I'm asking, what have you used in the past? And many people who have a history of self-injury have a preferred tool. And then we're talking about that tool specifically. So since I've already kind of dropped craft scissors on us, I'm going to continue with that specific example to give you an idea of how I have that conversation. So if I have a person who's telling me that they typically self-injure using a pair of scissors, I am asking about the cleanliness of those scissors. Are the scissors used for other things? How do you keep them clean? How do you make sure that they are clean before you are using them the way that you use them? And then I'm also talking about like the sharpness of the scissor. If they're using a like kids safety scissor to self-injure, they are doing a lot of damage to make the injury happen. But if they are using, your top of the line, like very, very, very sharp scissor, they might have a risk of hurting themselves more than intended. So we talk about, is this implement the right amount of sharp? And I talk to parents about that. A kid that is repeatedly scratching themselves with a safety pin. Okay, you're repeatedly scratching yourself with a safety pin. It's sharp enough, but it's not too sharp. I'm not going to do anything about that implement. But if I have a kid who's using like something that is very, very sharp, an X-Acto knife, something that is going to hurt them badly, I'm going to talk about, are we making sure that it's not too large, that it's not going to go too deep? How are we keeping you safe with this really, really sharp thing that you're using? This part of the conversation is tough. It's tough to know that I'm sharing it with you guys that are watching this, because I know it's hard. It's hard to hear. It's hard to say. It's hard to talk to a client about. It's super hard for support people to think about these things, and that is why it's so important. Because statistically, having conversations about suicide, having conversations about self-harm, we know that they do not increase the rates. But there is so much fear around talking about these things, about giving people ideas about what's going to happen if I have this conversation. So it's tough. And just as I want to acknowledge it with you guys, if you're having this conversation with your client support person, check in with them, take breaks, make sure that they know that they can exit the conversation if they need to, because it's a tough one. So moving to first aid supplies. If you have a person who is engaging in self-injury, they should have a first aid kit. And this isn't just for specifically self-injury, but I do talk about this with patients that are moving through some disordered eating. We talk a little bit about like things that you might need if they're like having a lot of purging behaviors, like keep your teeth safe. So they should have access to a basic first aid kit. For your adolescents, for your people that don't have a lot of autonomy, this is really the conversation you're having with parents of like, hey, your kids should have bandages, they should have Neosporin, they should have, good unscented soap and clean water to access to wash an injury if an injury has happened. And they should have access to those things without judgment or without strict monitoring. So if a kid is given a first aid kit and then their adult checks it every day to make sure that nothing's been used, they're not going to use it because they're going to feel guilt and shame or fear of punishment from that. So they should have access to it. Also things like scar cream, things like an unscented lotion for if we have an injury that's healing and feels a little bit uncomfortable. A lot of support people that I talk to now, just age range wise, a lot of people have tattoos. It's a pretty common thing. And so I can also tell support people like that I can see have visible tattoos, like treat this like a fresh tattoo. You're going to wash it with clean water and soap, and you're going to keep it nice and moisturized so it doesn't get itchy and uncomfortable. And then there are going to be specific things that you're going to reach out to a medical provider if you see happening. So if you have an injury that is bleeding and won't stop, and you have soaked through a gauze pad trying to stop the bleeding and applying pressure, and that bleeding isn't stopping, you need to seek medical attention right away. If you have an injury that has become hot or itchy, or you're having any red streaking, or you're having any type of like pus or drainage from an injury, you're reaching out for medical attention. And I am talking about this part both with client and with care provider, support person, adult, because this goes back to that quote earlier of people not seeking medical attention when they need it. And that your adolescent needs to be able to come to you and say, hey mom, I need to go to the urgent care right now, and know that they're not going to be screamed at. And that's building trust. So how do we make sure that both client and I'm talking a bunch about adolescents right now, but we know that that's where the rates are highest. Both client and support person have the trust in each other, and have talked about the fact that in the moment that trust is going to be hard. Hey, if you're in a space that you have a fresh injury that you realize needs medical attention, how are you going to feel about that? Is there going to be panic? Is there going to be fear? Is there going to be hiding? Is there going to be shame? Can we, talk how to tolerate some of those feelings? Has it already happened before that you had some of those feelings? Can we bring your support person in to talk about how to navigate that moment, to come up with a specific game plan of how we're going to move through that collaboratively and together to keep your body safe, because body safety's got to come first. And then the last part of it is we are outlining crisis in a really specific way. So I define that word at the beginning, that crisis means you're not safe outpatient anymore. People, the general population, people use this word a lot. People talk about crisis, people talk about having a mental breakdown in kind of a humored, a casual way, and that's okay. People can use those words. People can have dark humor. People and clinicians, many of us survive on our ability to access some dark humor. But we also need to know that when we are talking about true crisis, what the heck that means, because sometimes when we are in a moment that is very, very intense or very scary or very new, it can feel like a crisis. And somebody who maybe hasn't been in that definition of crisis that we talked about there in the beginning might feel like something that is not a crisis is a crisis, and treat it like a crisis, and therefore make themselves a less trustworthy person to come to. So we're also talking to support people about what is a crisis. Like, at what point is this person that you're supporting, and at what point are you, the client, the person who's engaged in self-harming behaviors, reaching crisis? What does crisis look like? What does it feel like? How do I access help? And what are my supports in crisis? When do I need to call the hotline? When do I need to call 911? And what's the difference between my parent driving me to the hospital and me needing to call 911? Sometimes just having this conversation about what is a crisis and sharing some language between adolescent client and adult can do so much for helping them access really good support. Means restriction. So I said it had its own slide. Here it is. This graphic here that you're looking at is specific to restricting lethal means with suicidal clients. So this is, I'm actually going to bounce back for a second. When you have your client, I'm really pointing at you guys. When you have your client that it is not indicated to talk about anatomy, to talk about body safety, to talk about like, hey, like let's use a different part of our body, a meatier part of our body. When that's not appropriate, you're jumping to this lethal means conversation, because this is the part that's really important when I'm talking about the right type of sharp, when I'm talking about taking away things that are really, really high risk. This is where that comes from, in that there are some things that can do damage, but are not likely to cause death. So some of the things that when I'm working with like a suicidal client that I'm talking about with lethal means is if your adolescent has the Costco value pack of ibuprofen in their personal area, in their own bathroom or in their bedroom or in their nightstand drawer or whatever, and they've got 500 tabs of ibuprofen, that is a very lethal means. If they have one of those little like travel things of ibuprofen, that is a significantly less lethal mean. If they have their whole bottle of whatever their psych bed is, they've got access to that for the month, versus if they got one of those little like pill containers. Highly lethal, less lethal. And in restricting lethal means, one, if you can't access whatever your chosen method is, or there is a delay here, you're less likely to follow through with either a self-interest behavior or, as with the graphic, a suicidal behavior. So when we think about somebody who's engaging in self-injury, and we think about this delay portion and access to your means and access to your sharps, what does this look like in practice? So one, it is storing whatever your chosen object tool is, storing it somewhere that's kind of hard to get to. So again, I used scissors earlier, so I'm going to keep scissors just to not throw out a bunch of different sharps. Because so if I have my identified tool and I keep it in a common area, so it's not in my bedroom. It's not right next to me. It's not where I sit all of the time. It is somewhere where I'm going to have to, walk past my little brother to get to it. There's a chance that I'm going to delay, that I'm not going to go there. I have it. I know that it's there, but I know that I also have to do a lot to get there. And it's going to give me pause. It's going to give me a moment where I am maybe considering my safety plan. Sometimes I will have client who is either unwilling or by their definition unable to give up whatever their chosen tool is. I will have them put it underneath their safety plan. So I'm not going to put it downstairs. I'm not doing that. I need to have it in my bedroom. It has to be in my nightstand. Okay. Can it be in your nightstand underneath your safety plan? Your safety plan's on top. You have to move the safety plan to get to the sharp. I once had a client who froze her sharp in a block of ice and kept it in the freezer. I thought that was great, because in the attempts that happened to get the sharp out of the block of ice, every single time the urge passed. So the block of ice itself was the tool. So delay, great. Substitutes we talked about, right level of sharp, something that is maybe accessed differently. I kind of got off track there because I'm trying to read and talk at the same time. Apologies. So when we're restricting lethal means, when we're restricting highly lethal means, or our access to means, we know that the delay is going to be helpful. Potentially substituting for less lethal means, that's really more about specifically suicide. That is going to help us reduce the rate of self-injury and reduce the severity of self-injury. Communication outline. So this is, firstly, disclaimer, this is not something that is coming from research. This is not something that I have pulled from anybody that has it's not research. This is an Amberism. I made this. And so I say this with that disclaimer of like, this is not something that I am pulling from a research source. This is something that is kind of a melting pot of things that I have learned from research sources, and I've put together and kind of made into my own outline, because I need an outline to be successful in these settings because this is a hard conversation to have. So these are my 5 steps to talking to support people about the person that they are supporting, about the person that is engaging in the self-injurious behavior. And the reason that I kind of put it in the steps that I put it in is because I have found that having a guideline for myself and knowing where the conversation is going next provides me a little bit of comfort, make sure that I get all of the information in. But it also helps me to really hold on to my expert seat in the room. And when I did this presentation last time and I had a live audience that was able to ask me questions, this is one of the things that I got a lot of questions about. So I also want to answer as I'm talking in, well, when the parent challenges you this way, or when they say this, or when they ask these questions. And I really sat with that after that last time that I presented about, some of those things. And I think that because this is so specific of a steps in a process for me, and because I'm also I have the privilege of being outpatient, and all of my clients that I work with have chosen to come to me. So I think that there's a lot of like, I'm not only in the expert seat of in the room, but the clients and the support people that I'm working with acknowledge me as the expert in the room. So I think that I have a lot of privilege there in the way that this conversation goes. I can see this going differently in an inpatient setting, but I would not change the way that I do it. So disclaimer there. So there's 5 pieces to this: safety, praise, support, action, and self-care. They have to go in that order. And some of them even have like a ABC order that they go in. When I am presenting this to a support person, very, very rarely, and I actually don't think ever am I doing this without first having this conversation with the client themselves. Because if I am asking for this, or at least after, if I'm asking for this of the support person, I need the client to also know that this is the ask. And I want the client to have the trust that this is the ask. Now, times that I don't have this conversation are if I have a caregiver that has either demonstrated in the past a very specific unwillingness to engage, and I know will not be able to follow through. I might have a shorter version of this or work up to bits and pieces of this, but I'm not sitting down and having this full conversation if I know that I have a caregiver that's not able to enact the steps. So I start this conversation by saying, like, this is a tough conversation. I'm gonna introduce some stuff and talk about some stuff here that is really, really hard. So hear me out, and let's give it a try. So safety comes first always. And this is something that, as soon as I say that, parents are like, yeah, safety first, safety first, safety first. And then I say what I'm about to say, and they're like, ugh. So body safety first. And even with a caregiver, I'm modeling what this conversation looks like. And I do this with my clients as well. So when you have a person come to you and disclosing self-injury, body safety comes first. Okay, are you bleeding? First thing that I need to know, if you're bleeding right now and you have not stopped bleeding, nothing else is happening. We need to stop the bleeding. Your body needs to be safe. Okay. If you're not bleeding, have you ingested anything? Have you taken any medication, any drug, anything that could be something that I need to know about to keep your body safe? Do you have anything that is red, streaky, hot? Do you feel like you have a fever? So I'm making sure you're not bleeding. I'm making sure you haven't taken anything. And then I'm asking if you feel like you have an infection. If those three things are no, then my second question is, do you still have an urge right now? If you're in the midst of a self-harm urge, or if that's the reason that you're coming to me, we're doing nothing else until we manage the urge. So those 2 things are, if we get through that and we just have somebody who's coming and saying, like, I either am self-harming, I have self-harmed, I'm sharing that I've had a relapse with you, and is okay on those first 2 checks. So they have body safety, they have brain safety, they're not in the midst of an urge. Then we're going to establish an immunity blanket. Okay. It sounds like you're in a safe spot right now. Let's start talking about it. And we're going to talk about it from the perspective of, like, I am here right now as a support person. You're not in trouble. Parents struggle with this because a lot of our adults, a lot of our grown-ups that are working with teens that have self-injurious behavior, go to punishment. This is something that you're doing that is bad or wrong, and therefore I'm going to punish you for that. I don't move on into the next part of this until I have a parent at least like 40% in agreement with, we need to not punish this. And I explained to my support person that I'm talking to, the reason that I'm saying you need to not punish this is because you are demonstrating to the person that you're supporting that they can come to you. If they know that when they come to you and you've demonstrated that when they come to you, they're going to be punished, they are not going to come to you. If you want honesty, if you want commitment or buy-in or any of these things, you have to establish yourself as safe. Even if that means they're coming to you and they've already done the self-harm, man, that's a bummer. It would have been great if they would have come to you first, but you're not saying that. You're saying, thank you. So our next part is praise. Thank you so much for coming to me. Thank you for trusting me enough to share this with me. Thank you for being so brave. I know that it's really hard to talk to people about this, and you're doing awesome, and it's scary. And I know that you have had 2 months self-harm free, and so this feels really tough right now. But thank you so much for sharing this with me. Again, I'm telling support people that this is how I want them to do this. This is also what I'm doing in session with clients when they come in and say that they have had a self-injury, is body safety, brain safety. I'm not doing the immunity blanket part because therapy should be an immunity blanket for the most part. Like, you're safe to share things here should be established session 1. And so I'm saying thank you. Tons of praise, tons of praise, tons of praise. And then I'm asking about support. Sometimes when somebody is coming and disclosing either to the parent or even to the therapist, they're disclosing with the idea that I'm either going to talk about the trigger or I'm asking for something here. I'm asking for a little bit of support. I have maybe identified a trigger, but those are the 3 things that I'm asking. So, thank you so much. This is really proud of you, super brave, da, da, da. Are you in a place that you can talk about the event, the trigger? If the answer is yes, then we're continuing. If the answer is no, then we're pausing and we'll come back to it later. Okay, so did you notice any specific triggers this time? What was happening before the urge started? Do you feel like this is something that was like urges were increasing, thoughts were increasing, and then this urge was just a really intense one? Tell me what got you here. Do you have any needs right now? Is there anything that you really want to process right now? Is there anything that I can do to help support this moment or support reduction of triggers, to support you in a future distraction, to sit down and look at that safety plan and see, okay, where did we go, where did we go sideways here? We have the safety plan and it was on top of the sharp, and we made it through the first 2 steps and got frustrated because it wasn't working, and so tossed the safety plan to the side and engaged in the self-injurious behavior. So can we identify where we could build in more support here? The next step of this is action. And this is something that I'm really, really talking to support people about. If you're asking kiddo about triggers, part of your building trust is if you say something during these 5 steps, you are following through. This is not a time to give empty reassurances. So if kiddo identifies that being repeatedly misgendered by grandma is a trigger, and I need time away from grandma, if you say in that moment, okay, you don't have to see grandma anymore, and then Christmas rolls around and you shame the kid for not wanting to go see grandma, no, you can't do that, because then you're breaking trust. So any promises or reassurances or whatever you're offering the person that you're supporting in this conversation has to be something that you can realistically follow through on. This also means that you can't say, call me anytime, 24 hours a day, and I will answer the phone, because that's not factually true. It's just not possible. So you have to make sure that whatever it is that you're offering in your support is actionable support. And if it's not, if the person is asking you for something that you can't give, say that and then validate that it sucks. If there is let's take grandma out, and let's say maybe it's a teacher that is engaging in a behavior that is triggering to the child. And we might not be able right now with the school to say, well, you never have to see that teacher again. But I can talk to the school, and then I'm going to follow through. I can reach out to your counselor and talk about what you can do if you get overwhelmed in that class, and then follow through. So there's some problem solving here if the person is able to do that at the time. The last part of this, and arguably the most important, is self-care. And this is kind of my like lean in moment with my support person, my caregiver, my adult, whoever they are. Of I go from being this kind of very intense, I'm the expert in the room, I'm telling you all of this information. I do that intentionally because I don't want to be interrupted during this conversation because it can get out of hand really fast. So I switch. I go back from that to like, now I'm a therapist again. And I say, look, I have just asked you to do a series of things that I know is really stinking hard. And I know is not going to come naturally to you, especially with parents. I'll say you are a parent, and I'm asking you to manage and regulate your own emotions when you are confronted with the injury of your child, and with the potential crisis. I've already identified crisis. They know what I mean. With the potential crisis of your child, I'm saying that I want you to not blow up, to not lose it, to not do a really reasonable reaction when you have that kind of dysregulating event happening in front of you, to the person that you care for, to the person that you love. But I am your kid's therapist and not yours. And so I am prioritizing their needs right now in this situation over what I know is a really, really big ask. I'm putting their safety first. And that's why I'm asking you to do something super duper hard. Interrupting myself. Typically, by the time I'm having this conversation, I have either been working with the kid for a while and therefore had some interactions with the parent, or I've gotten a ton of reassurance from the kid about their parent. So I kind of know who I'm talking to, even though the parent is not my primary client. So I know if I have a person who tends to be more reactive in front of me, or if I've kind of picked up on like, there's some family trauma going on here, and that's why they're acting this way. Or maybe, this sounds like a parent who might have actually engaged in self-injury themselves. And that's why it's triggering for them. I'm not calling any of that out, but if I know that I have a more reactive person in front of me, I am really emphasizing this next part, which is I would much rather when your person that you're supporting comes to you and says, hey, this happened, whatever it is, body safety, brain safety, and then before you get into the rest, thank you so much for telling me. I know this is really tough, and I appreciate you trusting me with this. And I want to show up for you. So I need a minute. We still have to ensure safety first, because we're not going to say I need a minute when somebody is potentially like physically injured in front of us and time could be of the essence. We have to have that like safety first mindset here, and really emphasize the safety first mindset to our caregiver that we're talking to. But I model this for them, and I say, this is how we say it. We go through the brain and body safety, and then thank you for telling me. I want to show up for you. But this is a big thing for me to hear about. This is tough for me to see. It's hard for me to see you hurting. Whatever those things are, whatever it is that they need to say, not all of those things, that's a lot, but one of those things. So, Mama's going to take a break. I'm going to step into the other room for a second. I'm going to take some breaths. I'm going to do what I need to do so that I can show up for you. And then after dinner tonight, let's sit down and let's have a better talk about this so that I can be calm and I can have my listening ears on and I can do what I need to do to be there for you. I will also talk to parents about this, like about the fact that like this is potentially going to be tough and triggering, and like take your time. And if you don't have a therapist of your own, and your kiddo is needing this kind of support, like it might be time. And also recognizing that this format is what I use. So I'm not just telling you to do this, but this is what I do with your kid. So they're going to know that this is what that looks like. And also, me myself as the as the expert in the room and as all of these things that I've established myself as, I have had to take breaks with clients before. I've had a client come in and not just disclose, but visibly show me significant injuries that were not in need of immediate medical attention, but that, like, wow, it's 2 o'clock on a Tuesday and I'm looking at this right now. That I've said, okay, body safety, brain safety. And then I've even said to clients before, gosh, this is a lot to come into right now. Let's take a second. Let's take a breath together. Let's just like sit with this feeling for a minute and acknowledge that it's big. Like, I have had to do that, and that's not my kid. So of course they're going to need that. Of course they're going to need that pause, that space, whatever it is that they need. But they need to communicate that and work on their regulation so that they can show up. Some final things here on physical healing, because we are running very, very short on time because I took a long time on that. Parents and support people do this wacky thing. I don't know who decided this was a good idea, but they do body scans sometimes, where they will like check for injury, like make a kid come out in a bathing suit and review their body. I really stress that this is not like a great or a safe idea. This can be super duper triggering for people. It can increase guilt and shame. It can also increase like hiding behaviors, or cause people to do other types of self-injury that they weren't already doing. I would also encourage your client themselves to talk to their support people about how they want to talk about their injuries. A lot of support people will say things like, oh my gosh, you're healing so well. You can barely see the mark. And that in itself can be triggering. So explore that with your client. How do you want to talk about recovery? How do you want to talk about, are you counting days? How do you want to talk about healing itself? Because your adult should be able to check on you and say like, hey, do you need anything? But also they need to be able to check on you in a way that's not going to trigger more self-harm. So for the recovery process itself, once we get into, we're having less frequent urges, we're doing better, we are maybe going longer in between periods of actually engaging in the self-injury. Relapse is not failure. Recovery is a process. Recovery is a long process. If we have to restart the clock and you're at day one again, it's not, I'm at day one, I'm starting from zero, all of my work is thrown away. It's, you know what, I've been to day 60 and I know I can get to day 60, and it's just one day at a time. A lot of folks seem to really like celebrating success, marking time milestones or urge milestones. I had 12 urges this week and only one instance of self-injury. If your client wants to celebrate that, talk to them about how to communicate that with their support people, how they can engage their support network in celebrating their success milestones. Maintaining support is really important. The coping skills, the processes that are put in place during that kind of active recovery of like, I'm thinking about this all the time, I'm noticing this all the time, my urges are really frequent, my urges are really intense, that cannot go away once we have some feeling of recovery. So if it is okay, you don't have to see, grandma who dead names you all the time, and then once you're doing better, now you have to see grandma again. We're not actually maintaining our supports unless the client themselves has identified, I am in a place that I am ready to engage with that thing that has been triggering and work through that, and I've learned how to tolerate this. So for questions, because this is pre-recorded, if you have any questions, if you want to talk about the way that I do this, if you want any specific bits and pieces of this, I know that having that one slide and that kind of breakdown of the support conversation was really beneficial to people last time I did this. But if there's anything that comes up as you're watching or listening that you want to talk more about, definitely feel free to shoot me an email. I'm happy to answer any questions or share anything further, elaborate on things if needed. So thank you guys for listening. I hope everybody enjoyed this and found it beneficial, and that you're able to bring this into your practice, whatever that is for each of you. So thanks so much. And if you're going to the day of CARE4U2, I hope to see you there and get to enjoy a really restful and restorative day together. Thanks so much.